5-minute presentations, 4-minute questions, correct? Okay, perfect. Thank you.
Okay, please sit down. I think the time is there to start. Welcome to the Fava session, which is going to last for about 1 hour. Together with me, I have Julien Colli from Brussels. I am Ruud Andersen from Oslo. Before starting the session, we have been asked from the Educational Committee of Issva that you scan the QR code that is sometimes coming up on the screen, but anyhow it's on the back side of your badge, and answer the survey there. We will have 5 presentations, but before the first, Julien Colli will give a short introduction to the Fava session.
Good afternoon, everyone. Thank you very much, Rune. So I have really a quick slides, 2 or 3 slides, just to give a quick introduction on the subject. So what is Fava exactly? So as you all know, this was first described and published, 10 years ago, as a distinct intramuscular vascular entity composed of venous malformation, dense fibrous tissue with excessive fat. It also contains some peripheral lymphatic cells as well as larger abnormal venous channels, as it was clearly described in the first article. Since then, there has been a few case series published. This list might not be exhaustive. They might not be complete, and some of the patients described here might overlap with each other, but you can have a small idea of the amount of cases that have been published on the subject. Now, in practice, this specific entity is actually much more frequent than what is reflected in the current literature. Most authors actually agree on a couple of points concerning Fava. Most authors all agree that this lesion has to be at least partially intramuscular, that it has to have some kind of a fat compartment. It should be a slow flow lesion, but we'll come back to that during the presentations. Those lesions majority present in lower limbs, that the main clinical finding is pain, that they seem to be caused by PIK3CA mutations. Those lesions seem to do not respond, or at least respond less to sclerotherapy, but that again we'll come back on it during those presentations. And lastly, that those lesions should be treated either with surgery or cryoablation, but that again we'll come back on that during this session. So this is the structure of this session. With the following 5 presentations, we would like to be able to answer those 4 questions. Is surgery the best treatment for Fava? Is sclerotherapy efficient with those lesions? Are there other treatment options? And are Fava slow flow only lesions? With that, I would like to invite Professor Goins from Uppsala University, Sweden, to start with the first presentation. Thank you very much.
Okay, thank you for accepting my abstract here. My name is Per Garvius, and I'm going to tell you about our experience of surgical resection of Favas in the lower extremities. I have no commercial disclaimer. My only disclaimer is that I'm not a surgeon, so I cannot answer any questions. So in this cohort, we have operated, or to say, we followed up 31 patients. Those were then 20 females and 11 men. The median age for surgery was 24 years, in a span between 9 and 63 years. The lesion was located in the foot in 2 cases, in the lower leg in 16 cases, upper leg 11, and then I also included 2 in the lower back, in the muscles in the back. 2 patients had previous surgery, and 6 patients had previous sclerotherapy. And the indication for surgery was like severe pain that limited everyday life, and that the surgeon actually made the judgment, I can take this out. And I should say all the surgeries were done by an orthopedic surgeon for adults, and then an pediatric orthopedic surgeon for the kids. So then how did we diagnose our father? It was based on medical history, the typical painful lesion, MR, where we saw the fat, and also this ectatic venous structure that we always have misinterpreted as venous malformations. And then an important tool is also the ultrasound to see the fibrosis. We did not do biopsies routinely, and the surgery was performed on an outpatient basis, but an important tool, I think, is to use the ultrasound perioperatively to guide the surgeons in the resections. So this is the setup. It's an orthopedic surgeon in the middle and then radiologist to the right, and then you have the ultrasound. And then this is how it looks when you're taking them out. And then you can also put your ultrasound probe on the tissue when you're taking it out to make sure it's actually in there, because we got patients that have been operated on other university clinics where the entire lesion was still there. It's not so easy for the surgeon when they open up and things come apart. So then the results. So the pain was then assessed by the orthopedic surgeon at the clinical follow-up. So 18 patients actually said, I have no pain. 6 patients said, no, it's almost gone. And 5 patients said that it's still some pain, but it's markedly less. 1 patient had no change in pain, and 1 was actually worse. And this is just the same thing in the diagram. So the ones that had unchanged or worse pain were the patients with the lesions in the back muscle. And so then about the results also when it comes to pathology, how well did our clinical measures actually fit with FAVA? So they were sent for pathology, and the pathologist said FAVA in 27 patients, venous malformations in 3 patients, and actually AVM in 1 patient. And that was a subcutaneous thing that we actually did not do the ultrasound before, so that's we should have done an ultrasound on that one. Molecular pathology, we didn't send everybody to molecular pathology, but the ones we did, which is 4 patients, we have some more coming, they were all PIK3CA mutated. And just some images of before and after. So this is FAVA in the thigh, in the lower leg, and before and after. And this is another lesion also in the lower leg before and after surgery. So then was this a dreadful procedure? No, so complications. The complications we had was seroma in 3 patients, and that led to like a delayed wound healing that needed some draining, and some of them got a small back thing there. 1 had an infection that required antibiotics. And all these occurred in lesions that were extending into the subcutaneous tissue, subcutaneous fat. 1 had an hematoma that, caused pain, but that resolved by itself. So conclusions and issues to discuss. To conclude, surgery in these patients are safe. It's done on a day. I mean, they walk out in the afternoon. But patient satisfaction was very high, so a standard question from the surgeon was, would you do this again? And most of them said yes. There was a very good correlation between imaging and the clinical picture and actually FAVA, and that subcutaneous lesions are more prone to seroma formation. And lesions in the back, they respond less well to surgery. So to discuss is what to do when surgery, surgery versus cryoablation versus sirolimus. And I have a few seconds more. So what to do when you can't do surgery? So this is a patient with a diffuse or a FAVA in the upper leg, not deemed possible to do surgery. And this is another one with like a diffuse lesion in the lower leg. So then sirolimus is an option for this, often good response. And one of the patients said, this is a miracle pill. I even feel better in my other leg. And I said, well, you don't have anything in your other leg. Which shows that sirolimus has many effects. So, sirolimus effect is not dependent on the mutation, so to say. But the question is then, how long can they stand being on sirolimus? Because many of them, after some time, they said they get side effects and they quit, but maybe they can take it in periods. So that was that. Thank you.
Thank you very much. We actually have a poll question to have an idea of the audience opinion on the use of surgery. Can we pull this up while we're getting that? I just have a quick question. Do you routinely do post-operative MRI when you operate those lesions?
I don't, but the orthopedic surgeon did, because he said, I want to know how it looks, because to get, he was, in the beginning when I tried to, he had the bad luck to be married to a radiologist that works with me. So that's, and the first case he said, he was, dissecting, he said, "Pat, this is as far as you can come from my orthopedic profession. I need to usually go to the bone, put the screw, and then get out. Now I'm standing here for like half an hour doing this stuff." So he does it, but I would not otherwise do it.
Okay. Thank you. While we're trying to get the poll question up, are there questions from the audience? Yeah.
Yes, I'm Marie from Philadelphia. I've struggled with this a long time. So FABA, some of them have sclerotherapy, so it's iatrogenically induced FABA versus a primary FABA. And so I suppose we have to get our definition correct, because we get lots of referrals in called FABA, but they've been sclerosed. And then taking those out versus taking out a primary lesion that has not fibrosis, hasn't got the nerve tacked down to it. So I suppose what I'm struggling with, in one of your images, I would have called it a vein malformation purely. What do we mean by fibrofatty anomaly? What I would call it is something where I'm struggling to get into veins, they're tiny, they blow, and you kind of fail sclerotherapy, as opposed to these big spaces that are sitting in fat that were always a venous malformation. So do we have a unifying definition of FABA, I guess?
I think there will always be some cases in the borderline being a venous or not, and we will not figure out, which shows here that 3 of them were actually venous malformation, at least according to the pathology report. Yeah.
It's Issva from Algeria. You said that you have operated 11 patients with leg lesions. Were they able to walk on their 2 feet, or were they obliged to walk only on 1 foot? And the pain, what was the cause of the pain? There was thrombosis, the D-dimer were elevated. I have some patients with FABA, but no one responded to sirolimus. So I am obliged to operate them, to find a surgeon who would accept to operate them. Thank you.
So you mean walking on the feet before surgery, or? Yeah. No, they were they were walking on both feet, both before and after, but there were painful lesions, So they said they got information, this is going to be a scar. So I want to take that, and they said yes. And a lesson I think is the stuff you get out, there you get rid of the pain. If you leave a piece, then the pain will persist. So the pain, I don't know, Ahmad maybe what is it that makes the pain in FABA? It's not phlebitis, that could be it also, but there's some neurogenic, inflammatory, pain that we don't really understand.
Next question.
I have 2 comments. The first one, we have a patient with inoperable FABA occupying the full forearm, and the patient was 1 year in sirolimus, another year on alpelisib, without significant improvement. I would ask somebody in the audience if you have experience with subtotal resection of FABA with a selection of the most involved muscles. And another question is an increasing fashion to operate FABA percutaneously, mostly in China. I would like to know if somebody has experience in the audience.
Sometimes they're tough to find, even in an open wound, with ultrasound you need to. So, yeah, you can probably do it, but I think surgery is wonderful, not being a surgeon, because you open up and you see it on the ultrasound. Sometimes it's like the surgeon says, I can't see it, it should be here, but then you take the ultrasound during perioperative and say, no, it's down there, and then you can see it. So I think that's the trick.
Thank you for the presentation, Per. Actually, it is really a diagnosis very suitable for surgery, because with ultrasound, even a surgeon can find it. Without ultrasound, training. It's really a tool guiding us to the right place, but it's also palpable. It's really a mass that is really easy to find. One comment is that we sent to the pathologist a little bit how you ask the question to the pathologist, you might receive the answer. And if you ask, is this a fava, we tend to have more responses, yes, it's a fava. But then when you ask specifically, or you sit with the pathologist looking into these specimens, we have a couple of cases with neural bundles. It's like what you see. I must address the question to Michel Wassef probably, because it's like hypertrophic nerve bundles in the lesion. That's what the pathologist has described for me. That maybe that is the cause of severe pain, because it's a little bit like pain that you cannot understand why. It's pain out of proportion or something. And then a question to you is the subcutaneous fava, because this is something very interesting what you're talking about, the subcutaneous fava.
Yeah, but
what do you think about that? Is there an entity that we will call subcutaneous fava?
No, I mean they rarely respect, compartments. It's like you can always see that there is something going to the, at least in the ones we have had. We haven't had many, but they are clearly, when you take and pull the fat, it's like fibrotic. You can put a piang and pull it, and it does not rupture. But normally it goes through the fascia a little bit into, that compartment. Yeah.
Thank you so much for your presentation. Sam Spencer from Boston. Pain is predominant, and we think it has to do a lot with the nerve invasion and compression. So I do a lot of extensive limb fava surgery and some paraspinal, and I have observed significant nerve compression. In some of our research, we've shown that if there's direct neural invasion, there is a poorer outcome. And then I would want to comment, I think Juan Carlos was asking, we do have some patients where I am doing a subtotal resection and we are doing multimodal treatment, and then the response can be better after there is less disease to medical therapy. So we have some examples now, which we have to publish in JOVA hopefully, showing that the patient can then do well on a lower dose of medicine.
Very often they come back, it's gone, but I have a little bit here, and you see, okay, there's a little bit, and then they go repeat surgery, just take that, and then they're fine.
Or cryo.
Or
if
cryo,
it's smaller,
yeah.
then the interventional
Yeah.
radiology may work better.
Thank you for presentation. Just a question. Do you have experience, or does anybody has experience in bleomycin electrosclerotherapy in fava?
Not me, I don't know if...
Might be an option according to you?
I don't know. The bleo guys have to try, the best people.
We must try.
But it's like I don't know. The